Thanks so much for those three really compelling talks. I think there are a few folks in the audience with microphones. Is there anybody who has a question for our panelists? Okay, so I will... Oh, we have a couple over here.
Hi, I have a quick question. Katie Jackson, I'm a master's student at UNC in public health right now. And I have a question for the first speaker regarding your innovation for weight loss. So you discussed briefly in your talk about how there's a large issue with children and the rising obesity epidemic in the United States, especially for young kids. Have you applied your innovation to deal with this issue?
Yeah, well, we're just beginning to. And one of the things that I think is maybe most surprising from the perspective of childhood obesity treatment is that one of the most effective ways to treat kids is to treat their parents. And so we're beginning to use the approach that I described here in a treatment intervention that's being led by my colleague Dory Steinberg and Sarah Armstrong in the medical center to try to improve. It's really directed at the parents with the hope that the effects will trickle down to their children. And if that approach works, then I think it's one, if we can get it cheap enough and scalable enough, then I think it's one that we can take really beyond the shores.
And was there another question over there? So somebody else got a hand up? No. So I'm going to pose a question to Gary, actually. I think that your talk showed us that we can really expect to bridge both geographic and economic divides with these technologies. And in thinking about how these technologies might benefit our aging population with chronic disease management, and having spent a lot of time providing IT support to my aging parents, I just wondered if you had experienced or anticipate sort of a generational divide in having these technologies adopted for health interventions?
So I think the surprising answer there is no. And in fact, there's some evidence that these approaches work better in older aged populations. The challenge is really one of what we call onboarding, so getting people up to speed and using the technology. Young people tend to get up to speed a little bit more quickly than do some of our elders. But once older populations get a handle on the technology, they use them with much higher levels of engagement than we find in younger age populations. One of the big challenges in younger age populations is that they tend to cycle through technologies. They churn them. They try an app for a little while and they're on to the next thing. And we don't see that same phenomenon. So I actually have the most hope in some respects for these kinds of approaches being used in older age populations.
Yeah, that's really interesting. I can see that. Anybody? Oh, right here. Great.
Thank you very much. Just a question to Jenna. We know that cervical cancer screening is a very complex activity, and there is a lot of cultural, social, economic factors that limit women from accessing cervical cancer screening. In the developing countries, you find that where the burden of cervical cancer is, you find that probably about less than 5% of women are able to access or to go for screening. Maybe I don't know what, as global health, we have done to be able to bring to these women who are at risk to the screening centers, because we know that the main problem is that women they don't know where to go for screening, and two, if they know where to go for screening, you find the screening is quite costly in some situations, or the screening centers are too far from each other. So I don't know what we can think about that as a global health leadership.
Yeah, great question. I think to answer that, it's best to talk about an example. And so one example that I saw this past summer in India was that they were doing these screening days. And they were sort of a whole host of medical screening technologies that they were using. But these women would come to a central location within a village. They would communicate with village leaders, and then physicians would come in on those days and screen women for a host of diseases, cervical cancer being one of them. And so I spoke to a gynecologist when I was there, and she said that it's hard to get women to come back, definitely. And what they would like to do is a single screen and treat approach, which is what the World Health Organization recommends. And she had actually described when they go back, if someone is positive for disease and they go back, they actually try to take this huge colposcope with them to screen them, and it really just doesn't work well, and they have lots of problems. So when I showed her this device, she was really excited about the potential of it. But I think you're right. I think this is a very complex problem, and our expertise is in one little part of the solution, developing a technology that's low cost that you can easily take with you to those sort of screening days. But I think it's so important to partner with other people who really understand what the challenges are in their individual communities. And so we're working with lots of people at DGHI in social sciences and medical professionals around the world to help us understand what the challenges are in each one of these communities so we can sort of tailor our solutions and the cervical cancer screening paradigm to something that works for them.
I'll just add to that, some of the work that we've been able to do collaboratively is exactly to try to answer that question, that the solution's not about the technology, it's about the technology enabling the solution. So it's not hoping that women come to a central location that may not be convenient, but with the technology that's now mobile and can be used not necessarily by the most highly trained people, you can now deploy it much more into community-based settings. You can move to a single setting diagnosis treatment as opposed to multiple settings. So I think for this to be impactful and scalable is going to require a reworking of the entire system of care. And to be able to drive that, at the center of it is the technology that enables the new models of care to come into being.
Yeah, that's fantastic. Valerie?
I have a question for all of you. I come from Peru, where we're doing there's been a lot of innovations in TB diagnostics and MODS, multi-drug resistance sensitivity tests, pneumonia, ultrasounds, etc. And I wanted to ask you, I hear about the reverse innovation and I hear about the projects, and how much collaboration and communication is there in the process? I mean, we've talked about reverse innovation where projects that are developed in countries, lower income, middle income countries might come back here, and you guys are talking about programs where some of the activities that you do go in the opposite direction. But in your programs, is there a communication that's incorporated to ensure that the devices that are being developed are the kind of devices that are being sought if it's not for Durham? And likewise, just what is the incorporation of collaboration, communication to ensure that devices are generated appropriately?
Sure. I'll start. You're right. Very much at the center of what we do is to build a network and a community. So it's not just about going from the U.S. to somewhere else or somewhere else back. It's very much about multi-directionality in the connections in the communities. As I mentioned, we work directly with 67 organizations that are operating in 49 countries. We understand the need to understand the context and having regional depth. So we have gone deep in understanding the healthcare innovation context in places like Latin America, how that differs from East Africa or Southeast Asia. And as part of that, trying to create local communities that can engage, but also connecting these nodes of innovation around the world that don't have to be connected to us. So an example of that, we have an organization in India that has developed a low-cost technology for eye screening. And we have an innovator that's working in Mexico trying to put low-cost, high-quality cataract surgery into practice to address more than 2 million unnecessarily blind people in Mexico. And what they were able to do through our community was connect to each other, and now the organization in Mexico has become the distributor for this technology from India and are deploying it to help them better screen and fit into their model of care. And we have same examples of that, of innovations moving across regions. with us serving very much as an active facilitator, but in no way serving as the node that things have to go through.
On a more micro level, I'd say that we probably earlier today, my team was in contact with our community partners as we're ramping up and developing a new app. In effect, getting feedback from folks on the ground about what they want to see and what they don't want to see, and that occasionally extends to the patient level as well. And this has been really instrumental. I had all kinds of fantastic ideas about the things that we should do in these kinds of treatments that were summarily dismissed, after engaging with our community partners. And it's been very important for the work. I mean, one of the things that very early on for us was just the choice of what ancillary care provider offered support in these kinds of treatments. One of the fundamental challenges and contradictions about digital health is that almost all digital health treatments work better when a human is involved. And so it sort of pulls a bit on what Krishna was mentioning earlier. These technologies often exist within a broader system of care. And the question about who in that system of care is delivering the sort of human delivered portions of the treatment is one that really has to be driven by community interests. And so that's been very important, I think, and critical to the success of our work.
And I think that to add to that, I would say that what you're asking about is the essence of what we call human-centered design, which is essentially involving the people that you're designing for from the very beginning so that you end up with solutions that are tailor-made to suit their needs. And I have definitely seen that play out in the Pocket Colposcope project that I talked about. We regularly get on the phone with physicians from around the world and have experienced all sort of Skype problems in the process of that. But I think it's so valuable to have those collaborations because, yeah, we understand one small part. And so I think that this project has really significantly taken off since we've started these collaborations, and that's in large part due to partnering with DGHI.
Great. I see Brendan there has a microphone.
Thank you all for these great presentations. Very exciting. In some ways, almost too exciting from the standpoint of, from my experience with global health, global mental health, and also the reverse innovations, is that the technology can seem to outpace the human resourcing and the financing. Mm-hmm. That what all three of you are demonstrating is how effective interventions can be delivered by people with limited levels of training, and how we can make this stuff widely available. At the same time, you're stuck with these archaic professional health systems and financing and reimbursement systems that impede the delivery of some of these activities. For example, Basic Needs is a great model, mm-hmm. but how do you finance a community-based, non-specialized service? You could get people who don't have nearly as much medical training to be able to do cervical cancer screening, but how do you get them into the health system? And the same with the diabetes programs and the issue of being able to deliver this stuff still with a human touch. Who is that human touch, and how do they become part of the health workforce?
Thanks. I completely agree. Right? So there's no point solution, as I call them, that's going to solve a complex problem, locally or in a different context. So part of the impetus for us creating this new Global Health Innovation Center was in recognition of the scope of the challenge is to build a mechanism to actually bring different disciplines around in the same way that DGHI has done more broadly for global health. So the model that we're now moving toward is really about 4 phases of work. The first phase is really around problem sourcing. So how well can you understand the local context, the key critical stakeholders, and what their needs are? Unless you know what problem you're trying to solve, you can't develop the right solution. And part of that problem sourcing is about understanding the constraints that a solution has to meet, whether it's professional scope of practice or financing. The second phase then is unleashing our innovation scouting capabilities through our network, through our partners. We know hundreds, if not thousands, of innovations that are happening around the world. How do we evaluate them, curate them around the best that are best fit for purpose? And we know that that's very unlikely to be any single one. So if you take mental health, it's likely to be a policy or financing solution in addition to a technology coupled with a different workforce model, all built around a totally different model of care. if you're going to be successful at scale. So how do we move to that third phase where we're able to integrate or bundle different innovations to analyze them and model the impact they could have in the local context where we're trying to solve a problem, and then circling back through a fourth phase, which is going back to the stakeholders who helped us identify the challenge, allowing them to be our demonstration partners to show its effectiveness, and as we refine it, to start with a pathway to scaling.
I'm not sure if I can really add much to that answer. But I would say that I think we're not entering into a vacuum. I think that there is something that exists on the ground in many of these places. And so if you can identify the key stakeholders and show them this technology, and then they can say where they think it would be appropriate or how we could change it so it would be more appropriate for them to use, I think that's the place to start. And yes, we're definitely, you mentioned task shifting. We're definitely interested in that, putting this in the hands of people who have just perhaps a few months of training. A community healthcare worker could potentially use this. And one aspect of the technology that I didn't talk about is we have a vision that women could self-screen, that you could get this small enough and cheap enough and use a small mechanism where you can essentially move the walls of the vagina out of the way so you can capture a picture of the cervix yourself. And that could help combat some of the stigma that's associated with a gynecological exam in many cultures around the world.
That's cool.
Thanks.
Yeah. Yeah, I mean, this is a really critical question, Brandon, there are no easy answers to this. I'll just say that, the question you're asking for us is central to the work. Our questions aren't simply, does this app work? It's how do we reshape, refit the existing clinical practice setting to accommodate this app? What does it cost? What are the long-term implications both for our patients, but for the providers, for the system? So this very question, I think, has shaped our work pretty dramatically, and it's happened because of collaborations with our community partners who really demand this. For example, one of the things that we found pretty early on, and was a bit of a surprise to us, is that in our settings you have an enormous amount of turnover in staff for these ancillary care providers, medical assistants, registered dietitians, those kinds of things. And when people are delivering, the people who deliver our treatments, these ancillary care providers, we've had almost no turnover in the last 5 to 6 years. Normally they turn over on an annual basis. And so that's been extremely important to the health system itself, and it's been a non-financial metric that they've been able to look to that makes them more eager to sustain this kind of innovation. We're working really closely with Eric Finkelstein, one of our DGHI faculty members, to do really comprehensive costing of nearly every part of our treatments to try to answer the questions that you're raising.
So I think we have time for one more question. Someone behind Brendan there.
Hi, excellent talks. I think that we talked a lot about innovation and how to take that to the masses in low resource settings. And Krishna, you talked about reverse innovation. So how much of innovation do you think is important coming from the same setting where it's used? Like, how do we find those bright spots, and how do we increase the number of such bright spots where you are building innovation within that same low resource setting? Is there a way we can help, or what are the shortcomings, not only financially, but how can they, do better?
Yeah, thank you. Great question. And I think we fully recognize that innovations don't happen in a vacuum. You've heard that. It's about context. So we have started to recognize and actually study in a systematic way what an innovation ecosystem looks like. So not a health system, but an innovation ecosystem. And I think that includes everything from the policies and regulations that facilitate or hinder the technology and service delivery models. It's about what financing is available, but it's also about things we may not think about. Is there entrepreneurial talent? So are there people, like you see, that are willing to spend years developing a technology and trying to create a model for it? Is there access to capital? If you have a fantastic technology, who's going to pay you to create the next model, to do the next study, to prove its effectiveness? Are there health systems that can actually incorporate it? Or do you have to build from scratch if you create a technology that doesn't fit into the current context of care? So we are now looking at opportunities to understand what innovation factors across the ecosystem may help or hinder the growth of innovation in the local context, and put programs in place, whether that is things like policy dialogue Or, for example, in Kenya a year ago, we held a health hackathon because we recognized that there's a tremendous entrepreneurial ecosystem, especially around Nairobi, lots of apps and technologies coming up, but almost entirely disconnected from the health needs of the population. So we created a platform where people who understood the health needs could come together with those who understood technology solutions and allowed them to work together in teams to move that conversation forward. So I do think in addition to helping recognize and curate and nurture innovation, we also have to do a lot around creating the right ecosystem in which innovation can thrive.
Great. So I'm getting some looks from the timekeeper, so we're going to have to wrap up. That was really fantastic. Let's please thank our speakers again.